In this video, we are going to explain the basics of what we call atypical preexcitation. In this slide, we show the 4 electrocardiographic patterns of ventricular preexcitation. In the previous video, we have explained the typical preexcitation that is characterized by a short PR interval, a wide QRS complex, and a visible delta wave. When the typical preexcitation is produced by a right-sided accessory pathway, the delta wave usually merges with the end of the preceding P wave so that the delta wave starts before the end of the preceding P wave. In patients with left lateral or septal accessory pathways that have a typical preexcitation, the delta wave usually starts just at the end of the preceding P wave or only a few milliseconds later. In this slide, we show 2 examples of typical preexcitation. In panel A, a typical preexcitation produced by a right free wall accessory pathway. Note the merging of the P wave with the subsequent delta wave. The vertical line signals the onset of the delta wave, and we see that the delta wave begins before the offset of the preceding P wave. On the right, we have another case also of typical preexcitation in a patient with a left posterior accessory pathway. Note that in this case, the delta wave begins just at the offset of the preceding P wave. Apart from the typical preexcitation, there are 2 other types of preexcitation: the so-called atypical preexcitation and the non-evident preexcitation. Atypical preexcitation is characterized by a PR interval that is not short, is more than 120 milliseconds. The QRS complex can either be equal to or more than 120 milliseconds or less than 120 milliseconds. What is constant in this type of atypical preexcitation is that there is always a visible delta wave. In the so-called non-evident preexcitation, the PR interval is normal, is equal to or more than 120 milliseconds. The QRS complex is also normal in duration, is less than 120 milliseconds, and the delta wave is invisible or barely perceptible. So the question is, why do we call preexcitation to this kind of non-evident preexcitation? Because there is an accessory pathway capable of anterograde conduction that is not evident during sinus rhythm because of the interplay in the atrioventricular conduction times over the AV node His pathway and the accessory pathway. We will explain this in the next video. Now we will explain atypical preexcitation in detail. Ventricular preexcitation is atypical when the atrioventricular conduction times over the accessory pathway are greater than 120 milliseconds, that is to say, when the PR interval is not short. This can occur in several circumstances, but the 2 most frequent ones are some inferior paraseptal accessory pathways and some left lateral atrioventricular bypass tracts. Depending on the duration of the QRS complex, we can distinguish 2 types of atypical ventricular preexcitations, both of them with a PR interval that is not short. In the first type, the QRS complex will be wide, that is to say, equal to or above 120 milliseconds. In the second type, the QRS complex will be atypically not wide, that is to say, of less than 120 milliseconds. Look at our example here, it was 100 milliseconds in duration. The QRS complex will be wide if the atrioventricular conduction times over the AV node, his pathway, are significantly greater than those over the accessory pathway. However, the QRS complex will be not wide when the atrioventricular conduction times over the AV node, his pathway, are only slightly above those over the accessory pathway. In the next video, you are going to see two examples of atypical ventricular preexcitation.